So I'm going to talk, Phil's introduction was perfect for this because I'm going to actually change a little bit and really talk about what's the utility of PSMA in the diagnostic setting and also as a predictive or prognostic biomarker in patients with prostate cancer. So I'm going to go in 10 minutes through three quick topics. The one will be kind of what additive information or does it provide PSMA imaging provide when compared to MRI, which is, of course, our standard for cancer detection nowadays. The second will be PSMA PET. What do we know about it as a predictor or prognostic marker of outcome? And then some newer work from my current SUO fellow, Adam Weiner, on PSMA as a biomarker of tumor biology and treatment response. So Phil already introduced this, diagnostic sensitivity at the time of surgery, about 40%, so I won't belabor that one. So this is a paper from a few years ago really looking at the sensitivity of MRI for detection of primary prostate cancer. And as you can see, and this was somewhat controversial when we published this because there were people saying that MRI was perfect, diagnosed 90% or more of all prostate cancers. But clearly there were a lot of tumors that were not visible by MRI. You're going to hear a lecture from Lori Klotz tomorrow about kind of what's the meaning of invisible, MRI invisible cancers, and oftentimes they are smaller, they're oftentimes less aggressive biologically. So the question though is, can PSMA kind of can it be synergistic, can it be additive, can it replace MRI? So there's a few papers that have been published so far on this. So this is a paper from Australia, from Yaxley's group, really large study where they actually looked at the sensitivity of PSMA versus MRI for the index lesion. And in this pretty large study, including many patients who had Gleason score of 3+4, so low intermediate risk cancer, sensitivity was about 80% for PSMA and 80% for MRI. If you combine the two together, you got 92%. So on the margins, the combination of MRI plus PSMA did add to the overall detection rate. And there were about 10% of cases that were identified only by PSMA and 8% only identified by MRI. And I'm going to kind of go into that in a little bit more detail with some studies that we are currently unpublished, but we're conducting right now. And there was, as has been shown by many, a correlation of the SUV with tumor grade. So this is a paper that we published a couple of years ago, kind of looking at head-to-head comparison of gallium PSMA PET with MRI using histopathology from a very large data set that we have of whole mount prostatectomies, in whom everybody had an MRI and many of whom had a PSMA PET. Now this was a higher risk category of patients. These were largely patients with unfavorable intermediate and high-risk prostate cancer because they were part of our prospective trial with UCSF and UCLA to get gallium PSMA 11 approved. But basically, we see something similar. We see that the index lesion in this series was detected by almost all PSMA PETs and by almost all MRI, and there was really just a marginal benefit if you added PSMA PET and MRI together. For secondary lesions, there was a little bit more additive information because there were smaller lesions, so there were a little bit more, fewer more cases where there was kind of a mismatch between the MRI and PET, and so there was a higher overall detection rate. So now delving into this a little bit more deeply with some recent work done by Ida Soni, who's one of our fellows, she really did a very detailed mapping of PSMA PET and MRI in whole mount prostatectomy specimens. This is kind of some of the methodology that she used. And she asked, what are the predictors of either concordance or discordance between MRI and PSMA PET? And what she showed is, number one, that kind of like with MRI, the larger the tumor size, the higher the likelihood that both MRI and PSMA PET would detect it. The lower the tumor size, the higher the likelihood that neither would detect it. So smaller tumors, kind of consistent with the MRI literature. And if you looked at the cases that were discordant, where MRI was positive and PET was negative, or PET was positive and MRI was negative, basically they were these intermediate cases where the tumors were kind of in the middle. They weren't large, they weren't small. The Gleason grades tended to be kind of intermediate risk, whereas high-risk tumors were virtually always seen both by MRI and PET, and lower-risk tumors virtually always not seen by MRI and PET. So clearly, there's some additive information that can be garnered from PSMA PET, but I think overall, if you ask, does every patient who gets surgery or radiation at the time of diagnosis who has a lesion on MRI, do they need a PET scan for diagnosis of the primary tumor? I think the answer right now is probably no. I'm going to skip this slide. So the second topic is really PSMA PET as a predictor of outcome. This was a really nice study looking at SUV, quartile SUV, showing that there is a correlation of SUV max with biochemical recurrence. Tumors, if you look at all Gleason scores, tumors that had the highest quartile of PSMA expression based on PET had a overall higher risk of biochemical recurrence compared to those that had lower expression. And that was most prominent in lower risk tumors, Gleason 7 and 6. For Gleason 9 and 10, didn't really add a lot of information because most patients do poorly, unfortunately. So this is a study that we just published looking at this same question about whether or not, how did PSMA perform as a prognostic biomarker in patients undergoing surgery. This is from that large study, prospective study that we performed. And basically what we did is we compared the ability of PSMA PET prior to surgery together with the CAPRA score, which is a very well-known and annotated prognostic biomarker system for prediction of biochemical recurrence. So in patients prior to surgery who had a high PSMA versus low PSMA on their PSMA PET, overall there was some prognostic information. Higher PSMA was correlated with a higher risk of biochemical recurrence, and very similarly, the CAPRA score, the preoperative CAPRA score, performed very similarly. But if you looked at patients based on their PSMA PET, their end stage, their node stage, or their metastasis stage, those patients, kind of common sense, if they were PSMA positive, they had N1 disease, those patients had a much higher risk of biochemical recurrence. And it outperformed the preoperative CAPRA and even just the preoperative, just high-low PSMA in terms of prediction of biochemical recurrence. And essentially, it provided similar information to the CAPRA-S score, which is the postoperative pathologically based CAPRA score. So clearly, a PSMA PET in higher risk patients who may have nodal metastasis, the presence of a positive node or positive metastatic disease is a very important prognostic marker and may help in patient selection. So it clearly has some prognostic utility. And then the final topic I'll go into for the last few minutes is PSMA as a biomarker. So just as MRI provides more than just yes, no answers about whether or not there's cancer, and actually does provide some functional and biological information. The question is, does PSMA provide any biological information that might be useful for selecting treatment or for predicting outcome? And this is just kind of an unusual case, but that we certainly do see, of a patient who had a very large tumor on MRI, but on PSMA PET, and this is the tumor here, it's completely negative. And this patient also had what appeared to be a fairly significant node, but had no uptake whatsoever. So it's a case of a guy who had a Gleason grade 5 cancer in his left base, but PSMA PET was negative. So that's kind of interesting. So what is that telling us about the tumor? So that's just a case example. So what we did is first, this is Adam did this work, not myself. We looked at TCGA based on PSMA RNA expression, and we asked what signaling pathways are associated with tumors that have high PSMA expression versus low PSMA expression. And as one might imagine, the androgen receptor, androgen response pathway, or androgen-regulated pathways are upregulated in PSMA high tumors. PSMA is regulated, at least in part, by AR, by the androgen receptor, so that makes sense, and it's been published previously. But certainly, patients who have very high PSMA expression are more likely to be dependent on those tumors are androgen-driven and androgen-dependent. It's also associated with markers of metabolism and cell growth and division. Interestingly, tumors that were low in PSMA, and again, these are largely higher risk tumors that we were looking at, were enriched for pathways such as inflammation, hypoxia, and epithelial mesenchymal transition, which is associated with markers of stemness and plasticity, lineage plasticity, like the conversion to neuroendocrine prostate cancer. And overall, if you look at PSMA in adenocarcinoma versus neuroendocrine prostate cancer, PSMA is highest in adenocarcinoma and lowest or even negative in neuroendocrine prostate cancer. And most likely that patient I showed you with the Gleason 10 cancer at a negative PSMA may well have had neuroendocrine prostate cancer. I don't know all the details. Now, what does this tell us in terms of response to therapy? This is a study looking at response to salvage ADT in patients who had PSMA PET, and basically could show that patients who had high PSMA expression seemed to do better after ADT than patients who had low expression. So this may actually provide treatment selection information that might be useful. As I said, PSMA low tumors are marked by multiple markers of stemness. These are a number of signatures that we looked at. Now, how does this potentially translate into clinical meaning? So PSMA low tumors were associated with a shorter time to recurrence in patients undergoing primary radiotherapy. This is another retrospective cohort, but basically there was clearly an association between low PSMA expression and resistance to primary radiation. This might be made up by using higher doses of radiation, but suggests that PSMA low tumors, high-risk PSMA low tumors, may be associated with resistance to primary radiation and enriched for markers of lineage plasticity, such as conversion to neuroendocrine prostate cancer. So I'll conclude, PSMA PET can improve detection of cancer when added to MRI and vice versa, but generally speaking, at the margins, I don't think every patient needs it, even though many patients are having both ordered all the time. PSMA PET is a predictor of biochemical recurrence and improves upon standard pre-op factors such as Kappa score. PSMA PET may provide important biological information to aid treatment, and I didn't have time for this. I'll talk about this in one of the cases, radio-guided surgery for removing extraprostatic disease. All right, thanks very much.